All right. Yeah. Hi, everyone. Thanks for joining us this evening. Yeah, I'm Josh Grapp. I'm an optometrist. I currently serve as our section counselor for the vision care section. And I have the privilege of introducing our first speaker, Dr. William Padula. So, Dr. Padula, he is the director of the Padula Institute of Vision Rehabilitation in Guilford, Connecticut. He's adjunct professor at Western University of Health Sciences College of Optometry and Salus University of Health Sciences College of Optometry. He's a senior fellow at the National Academy of Practice, a fellow of the American Academy of Optometry, and member emeritus and fellow of Neuro-Optometric Rehabilitation Association International. Dr. Padula is the founding president of the Neuro-Optometric Rehabilitation Association, the founding chairman of the American Optometric Association Vision Rehabilitation Low Vision Section, and created the first low vision clinic at the Zhoushan Eye Research Hospital in People's Republic of China. Dr. Padula has authored numerous publications, including 3 books and a chapter on vision rehabilitation in brain injury medicine. Dr. Padula has been awarded 16 U.S. and international patents. Dr. Padula has been awarded the Most Innovative Invention Award at the American Congress of Rehabilitative Medicine Launchpad Competition and the Advancement of Vision Rehabilitation Technology Award at the American Academy of Optometry Bright Ideas Competition.
Very little is really processed in terms of rehabilitation for these individuals through an understanding of the visual system. Primarily what has occurred is a model of treatment about eyes and neurology and function has prevailed since the mid 20th century. It's been my interest and journey over the past 45 years to explore the relationships of vision processing in the brain and its relationship to motor function in particular, but as well as to other sensory motor information. So I'd like to share that information and some of the research that I've established. I have no disclosures of financial interest at this point. And Dr. Colfern, perhaps you'd like to launch that public question. So when there's a visual processing problem, we have to grasp the implications about the visual process and its relationship to the neurology and the motor system. We have to look at the possibilities for how this relates to the maximizing potentials for rehabilitation. And this is going to create a new model of vision. So there's a paradigm shift here that I'm going to take you through rather rapidly. If there's a neurovisual processing dysfunction, we know that it can affect the eye, visual acuity, visual field, and ocular motility. But what we've paid little attention to is the brain's relationship to neurovisual processing as a dysfunction and how it relates to posture and balance and spatial orientation, attention and concentration, and binocularity. An injury to the brain can cause a loss of acuity, visual field, restriction of ocular motility. It can also create the symptoms of diplopia, blurred vision, inability to tolerate busy moving environments. That's one of my favorite questions to ask patients when they come in after a concussion, because their visual process is compromised to the extent that just going to a supermarket at 5 o'clock presents an overwhelming amount of stimulation to their brain. Headaches, asthenopia, even hallucinations. I've had patients where they've had so much focalization to the visual process that they project their own movements of their eyes into the world about them, seeing vertical posts appearing to move and interpreting them as snakes jumping onto the floor, and photophobia. To understand this in a more complete manner, we have to go back and look at the models of vision. There's a functional model where we look at the visual process in relationship to eye muscles and nerves. And if there's a convergence problem, look at it in terms of a weakness of the muscle or nerve function. There's the medical model, which looks at it in terms of ocular health. But there's another model, and it's a bimodal visual processing model. And it was discovered by the top visual scientists of the 20th century, particularly by a researcher by the name of Trevarthen from University of Oxford, England, and later Harvard. He was studying primates, and he discovered that these primates functioned in 2 different manners. They had a focalization, which he called the focal process, which they could identify detailed discrimination, attention, concentration. And I've added to this that it's a conscious mode. It's always in the present. The other process that he recognized was one of spatial orientation, posture, movement. It affects balance. I've added to this that it anticipates change and it's preconscious. And if you look at the neurology of the two systems, which we'll be doing in a moment, you'll recognize that the focal process is really the second process we're born with. The myelination of the central nerve fibers from the macula aren't even present at 9 months birth. What's there initially is a spatial process coming from the peripheral retina. And the spatial process has to connect with the proprioceptive base of support. The spatial process, when it does this, becomes gravity specific. When the focal process evolves and it develops, it disassociates from the spatial process at a specific point in child development so that it can attend to curiosity for other information and to occupy our attention. But the spatial process always remains preconscious, not unconscious or subconscious. It's there constantly for the planning for the next event. It's really where the plasticity of the visual process lies. So the preconscious process is proactive. Once it matches up information with the proprioceptive base of support, and it's through a very fast neurological system, which we'll talk about in a moment, it has to feed forward to pre-program the higher cortical process. And then it receives feedback for correction. This process of focal and spatial processing in bimodal fashion operates similar to a computer. If you want to run an application, you first have to turn your computer on and then boot up the operating system, which then becomes your managing operating system to create a platform base for support for the applications that you're going to run. Well, the spatial process works in much the same manner. And it has to constantly readjust and adapt to information, both from feed forward, from the proprioceptive base of support, as well as from feedback. And this is where the plasticity lies. So the neurology of this system, this is a graphic that I created because I was trying to capture this organization of the spatial visual process, which is launched primarily from the peripheral retina. And it's delivered not by the central visual processing system, which is the parvocellular system, to the occipital cortex. It's delivered by the magnocellular system, which feeds into the superior colliculus, seen here in this build-out. And the superior colliculus is there for a reason because it's gaining all this information about spatial visual process, and it has to match up with information coming in through the spinal tectal tract, which is proprioceptive information from our base of support. And this has one synapse or stop, and it stops right at the superior colliculus, where information is then sent to all the extraocular motor neurons. It stabilizes with the inferior colliculus, which is the auditory spatial visual process. And once this occurs, it feeds forward to pre-program the supplementary eye fields of the frontal lobe, parietal lobe, and occipital lobe, to name several. When the system is compromised, it produces a condition that I've termed post-trauma vision syndrome. I published this in Brain Injury a number of years ago with my colleagues, Dr. Ardress and John Ray. And we used visual evoked potentials to evaluate patients with brain trauma. And what we discovered was that the characteristics of the visual process following a brain trauma was frequently exotropia or exophoria, a convergence insufficiency, accommodative insufficiency, difficulty with oculomotor movements, as well as increased myopia. The symptoms frequently were diplopia, blurred vision, inability to tolerate busy moving environments again, headaches, astinopia, hallucinations, and glare sensitivity and photophobia. We did visual evoked potentials on every subject, and this was one of the subjects. Now, this subject had a severe whiplash and was in the hospital, and he couldn't open up his shades, couldn't turn on the television, couldn't turn on any lights. That's how light sensitive he was. He wanted nothing more than to read his Bible, but when he tried to read the Bible, the words kept moving on the page. The visual evoked potential shows the P100 of an amplitude of about 4.38, which looks like a normal visual evoked potential. But we hypothesized that the spatial visual process was a function of the amplitude of the visual evoked potential P100, and that the latency was more a function of acuity and attention. And we decided that what was occurring with many of these patients is they showed compressed visual fields, literally a compression on the visual system. Taking it into the bimodal visual process, what was happening is the spatial process became compressed and your central visual focal process expanded. Knowing lenses and prisms and optics the way I did as an optometrist, I realized I could use base-in prism before both eyes, which will essentially compress central and expand peripheral. And when we did this, we immediately got an increase in the amplitude of the P100, in this case to 7.32. The results of the statistics of this study demonstrated that statistical significance that when base-in prism was used with these patients showing P100s, they all had increased amplitudes, indicating that the spatial visual process is a function, or that the P100 is a function of the spatial visual process. And number two, that prisms could be used to counter the effects of the concussion compressiveness. This was a psychiatric nurse following a head injury. She couldn't function as a psychiatric nurse any longer. This was her visual evoked potential. Treated with base-in prism for 4 weeks when she returned, this was the visual evoked potential. So it indicates that not only is a spatial visual processing compromised, but that by utilizing prisms properly, we could actually affect brain function, not just in terms of the compensatory manner, but actually to rehabilitate the patient. So the results of the research showed that all the patients in the experimental group had reduced monocular and binocular acuity, difficulty with pursuits and saccades, an accommodative and convergence insufficiency. They overfocalized on isolated detail, and this intensity was so strong, and we'll talk about this in the next slide, that it produced myopia. And many of these patients were hyperopic before the injury. And they had increased exophoria. We eliminated all strabismus from the study because we wanted to do the visual evoked potentials binocularly. The control group were normal for all those things just mentioned. This study, not many people know about this, so I thought I'd bring this out. I didn't realize it, but it was picked up by Senator John Kerry at that time, and he created a bill around post-trauma vision syndrome, Senate Bill 1999, to develop centers of excellence within the DoD and Veterans Administration for the purpose of assessing and as well as treating our wounded warriors for post-trauma vision syndrome. A similar bill was picked up in Congress. Both bills were picked up by the Wounded Warriors Act. And that's how vision rehabilitation and neurooptometry was drawn into the Intrepid centers in the DoD through congressional mandate. I wanted you to take a look at this subject. This woman, she'll stand up, had her own construction business. She lived out in Arizona. On her way to work one day, and she was T-boned by an 18-wheeler doing about 60 miles an hour. This is the way she walked for about 2 to 3 years. She had cervical injury, back injuries. I think she had several fractures of her back. She had been through PT, OT, physiatry, Botox, a number of things. I want you to pay particular attention to the abnormal postural tone. She also has a visual midline shift syndrome, which we're going to talk about shortly. And come back again, please. What I'm going to do is move this forward now that you've seen that. Okay, I'm putting on some prisms right now, and I want you to watch what happens to her body. With the shoulders drop, the tone drops immediately in the shoulders and the arms. She's wearing base in prism. She's taking a longer stride in the base of support narrow.
We'll keep them on for another walk down and back. And we'll come back on.
Even her pivots are better. She's turning her head and looking ahead of the turn. I've just taken the prisms off. Watch what happens to the abnormal postural tone. It returns immediately. The implications of this is that the visual process, the spatial visual process, is far more complicated than it's been given credit for. And that the implications are also that if we understand the bimodal visual process, we can create a rehabilitation model around this, which neurooptometry has done, and we can influence the effect on brain function for concussive patients. What does it look like for a patient who's had a concussive experience? The intense isolation on detail is very much like if you've ever driven at night in a snowstorm, you can still see the road. But if you make the mistake of hitting your high beams, suddenly the road disappears and all you have is this meteor barrage of snowflakes coming at you. That's what they experience every day. The more severe, the more movement there is in the environment that they're experiencing. And it causes a perceptual tunnel visualing. So if you ask them to read a letter on a chart and walk toward the chart one step per letter, after they're done, you ask them what they're seeing, they will tell you they saw only the letters and not even the room. That's the compression of visual space. But the injury of post-trauma vision syndrome affecting the spatial process can also cause another rather strange event that I discovered and I called visual midline shift syndrome. It was published in Neurorehabilitation and Brain Injury for 2 papers. This dome that I've got here is similar to the way in which our spatial process works if we don't have any neurological problems. Each of us, think of this Z platform here, has a spatial equalization in all factors and all dimensions of the zone. But given a compromise from a stroke or traumatic brain injury, such as with this hemiparesis on one side, you can see how the body gets compressed and shifted to the right. And this woman is actually leaning past her heel. This is a visual midline shift syndrome. When there's a shift in the visual midline, what happens is the brain perceives that as the center of the body. And the shift will be in the direction of the midline. Visual midline is at one with the center of mass, which is located right about where the navel is. When there's a shift in visual midline, center of mass moves in the same direction. After I discovered post-trauma vision syndrome and realized what could be done with prisms, I thought there must be compression of space on one side, causing a shift away from that side. So I decided to take yoked prisms, 2 prisms with the base end in the same direction, placing the base end in the direction of the affected side. What I found was that the visual midline came back to center. And I had stroke patients with hemiparesis weight bearing on their affected side within a few minutes. So a yoke prism has expansion and compression. And when utilized properly and at the right position and right axis, it can have a significant effect on posture. I use it now in my own gait lab, and you can see here the effect of using the gait lab. This woman had a stump after a motor vehicle accident. Physiatrists, physical therapists, no one could understand why she stumped the right toe, but a full footfall on the left. When she came to me, I recognized and diagnosed a visual midline shift syndrome. immediately with the prisms, you can see how she extended the right heel down. This gentleman worked in a boatyard by day and went to school at night for engineering. Sold a boat, went back the next day with his partner in a forklift, who picked up a 3,000-pound boat. He was walking next to the forklift when the forklift failed, dropping the boat on his right shoulder and neck, taken to the hospital, CAT scan negative. He was released. Following day, this is how he got out of bed, kept complaining about something wrong with his eyes. Doctors that examined him said nothing wrong with your eyes. One doctor even put down that he was malingering. This is a visual midline shift syndrome. I'm treating him now with yoke prism. This was the first night he came into the office. He wanted to wear these glasses for the rest of his life. I said, no, 2 hours a day. And I prescribed a weaker prism. He's wearing an 18 diopter yoke prism, both eyes. I worked with him and kept reducing the prisms. A year and 1 month later, I saw him and prescribed the 1 diopter yoke prism, and I've never seen him since. These are all more patients. In conclusion, a concussion or a TBI affects neuroplasticity, and it does this by affecting the spatial visual process. The discoveries of 2 syndromes, post-trauma vision syndrome and visual midline shift syndrome, are very prevalent in the population of patients with concussion. By understanding the relationships of the spatial visual process and how it serves as a platform base to higher visual processing, it gives us a new means by which we can look at the significance of vision in its relationship to not just attention and concentration, but to posture and movement, but also to recognize that without organizing the spatial visual process in relationship to the proprioceptive base of support, many of the characteristics of convergence problems and accommodative problems will be sustained. Although I don't do any vision therapy with these patients any longer, what I do is when I see a convergence insufficiency, I treat them with base and prism. I have patients that say to me on the spot, I want to have vision therapy. I say, wear these prisms and come back and see me in 4 weeks. I've had patients with convergence insufficiency receded to 18 inches, meaning diplopia within an 18-inch range. And they come back in after about 4 weeks, and they're converging into 3 inches, and I didn't do any therapy. So we stand on the threshold of a new dimension for optimizing brain processing by affecting the spatial visual process, and we can integrate this through neurooptometric rehabilitation, a new specialty. I was one of the leaders and founders, pioneers with this, and was the founding president of the Neurooptometric Rehabilitation Association. It enables us to assess and develop new means for treatment for post-concussive patients. Thank you very much.
Yeah, thank you very much, Dr. Padula. That was great. And I now have a new tool for some of these patients that I see. So again, there will be a time for questions at the end of everything. And so Rajiv, you can have the mic now.
Great, thank you. I want to take this great honor to introduce one of our faculty members here at the University of Rochester Medical Center, Dr. Steven Silverstein. Dr. Silverstein has been a great colleague of mine and has also mentored me through some research as well, some of which he'll be presenting today. So Dr. Silverstein is a professor of psychiatry, neuroscience, and ophthalmology at the University of Rochester Medical Center and a member of the Center for Visual Science. He is also the George L. Engel Professor of Biopsychosocial Medicine, the Associate Chair for Research in Psychiatry, and the Director for the Center for Retina and Brain at the University of Rochester Medical Center. Dr. Silverstein is former president of the Society for Research in Psychopathology and the former chair of the American Psychological Association's Task Force on Serious Mental Illness. Dr. Silverstein received his PhD in psychology from the State University of New York at Buffalo in 1989 and completed his internship and fellowship at Cornell Medical College after that. His research interests are risk factors for serious mental illness and treatment of first episode psychosis, and also retinal, perceptual, visual, and cognitive changes in people with schizophrenia and rehabilitation of those impairments. He's also working on retinal biomarkers of changes in brain and cognitive function and other conditions affecting the brain, such as heart failure, small vessel disease of the brain, and sports-related concussions, which we'll hear about today. Finally, Dr. Silverstein is a champion for addressing mental health issues related to vision loss and their treatment, and is one of the champions for vision who is not an ophthalmologist or optometrist. So with that, I welcome Dr. Silverstein to present retinal biomarkers of repetitive head impacts in football players.
Okay, as I was saying, thank you, Rajiv. That was a nice introduction, and I'll be talking today about retinal biomarkers of repetitive head impacts in college football players. And as Dr. Ramchandran mentioned, this is a project that was a really nice collaboration between me, who's a vision researcher in psychiatry predominantly, and Dr. Ramchandran, who's in ophthalmology as a retina specialist, and then Jeff Bazarian, who works in emergency medicine and is a concussion expert. I have no disclosures to mention, and I also wanted to mention that the paper that describes the study I'll be mainly focusing on has been published and is available, on the internet, open access, in the journal Biomarkers in Psychiatry, and came out just a few months ago. So the aims of this project were really to look at football players who had a history of concussion and football players who did not have a history of concussion. And one of the aims to see, are they different in any way in terms of retinal findings? We also wanted to study the football players at the beginning of the season, actually before the season, and not only before the season, but right at the beginning when they first came back to campus in the summer. So before they really had much football practice for that season. And then look at them again at the end of the season, and then 4 months after the end of the season to see what changed. So we're looking at people with a concussion history versus without, but also changes in all football players over that short football season, 3 months or so. And in addition to looking at changes overall, we wanted to see if the amount of change on any of these retinal markers was related to the number of times they essentially were hit in the head during the college football season, which, as I'll say in a minute, you can now measure pretty accurately with these in-helmet accelerometers that record every impact. And really the idea of this is that Jeff Bazarian and others have shown that not just professional football players, but even college football players have significant changes over the course of even a single season in the white matter in the brain and on MRI findings, other MRI findings as well. So we wanted to see if looking at the retina, which is a part of the central nervous system that's much more accessible to measure directly and with much higher resolution than MRI, if we would see similar things that have been shown in brain imaging studies. So in terms of the background of this, as I mentioned a minute ago, the retina is part of the central nervous system. And I realize that many of the people listening to this are ophthalmologists, so that's not a surprise. But for many people, that's not it's not obvious why anyone would look at the retina if you're interested in the brain, say. And of course, there's much evidence that when you see changes in the retina, especially atrophy and what looks like neurodegeneration in the retina, you typically find that in the brain as well. And that parallelism has been demonstrated in a number of conditions like Alzheimer's disease, Parkinson's disease, MS, and a number of severe mental illnesses like schizophrenia and bipolar disorder. And even in a healthy population, you'll find relations between things like retinal neural layer thickness and cognitive function and brain imaging findings. So this has led to the idea that the retina is a window to the brain. But despite much research now with neurodegenerative and severe mental illness conditions, there's not as much research on retinal changes associated with brain trauma, especially with milder and repetitive brain trauma that doesn't lead to immediate medical attention. But just to cite give you some idea of the research that is out there, there's research on animals that shows that after being exposed to blasts or other form of impacts to the brain, that within weeks or months after that, you can see thinning of retinal layers, even when there is no direct impact to the eye. So again, it's as if there's an effect on the nervous system and it's affecting the brain and the eye together, even if the eye itself wasn't injured immediately. There's been research also in athletes, including in Olympic boxers, but also in retired athletes. But I want to emphasize here, particularly in the boxers, what you typically see is when there's with boxing, there'll be thickening of retinal layers, and but overall, the thickness of the retinal layers is thinner than in other people. It's just that there's thickening when there's when they're actively engaged in boxing. So this suggests that there's both some acute changes that are related to inflammation or some type of other processes that are related to thickening of the tissue, but that over time, there's essentially degeneration, not unlike what you see in MS, where in an acute episode, you'll see swelling, and then after the acute episode, you see loss of tissue. And of course, in veterans who've experienced mild TBI, there's can be thinning or thickening. So again, it depends when you look at somebody. Now, this is very important for public health, which is a group that's putting on this webinar. So, for example, many people have concussions, millions of people just in the United States every year. Many of these are from contact sport athletes. About 10% of them have at least one concussion in any given season. This is something that used to happen to me, so it's partly why I'm interested in this. The majority of people, especially in the past, will continue to play despite symptoms because coaches weren't particularly attuned to this problem, and the kind of the ethos or mentality was to just continue to play. And in many cases, coaches aren't even aware that people may have had a concussion. And as I mentioned, even a single season of football or soccer, even when there isn't a concussion, can cause changes in brain structure. So this is all about concussion. But what I also wanted to focus on is people who do not have a concussion, but just experience repetitive head impacts, because this is much more common in many sports and occupations. And what makes it more dangerous in a way is that, if you have a bad concussion, if you get run over by something or, slam into a pole or whatever, there's a good chance you'll receive some medical attention or go for it, or someone will tell you should. But if you just receive, been in a football game where even if you're wearing a helmet and you have a number of head impacts, often you're not aware of anything. There are no observable signs of injury. You're not feeling or seeing things any differently. You're not impaired in any way. Nope, no one's going to really tell you to go see a doctor. So essentially, people who experience repetitive head impacts are unlikely to be evaluated medically unless there's some very severe long-term change. Now, we know that in military personnel, repetitive head impacts in the absence of concussion can lead over time to post-concussive symptoms. So they can look like they did have a concussion, including cognitive and emotional changes and dizziness, balance issues, etc., and changes on MRI. And the more exposure to blasts, so here I'm talking about overpressure, where you don't actually have a head injury, like an open head wound. You have just had exposure to blasts, so there's been force against the head. And the more times you are exposed to that, or the more you've been exposed to it, the more likely it is that you'll have these post-concussive symptoms. In addition, repetitive head impacts have been linked to an increased risk of long-term cognitive dysfunction and depression, and in postmortem studies to CTE, or chronic traumatic encephalopathy. And one of the reasons we wanted to study football players is that the postmortem studies of brains of former contact sport athletes, so boxing, people who did boxing, hockey players, football players, whatever, are quite similar to the findings in people exposed to repeated blasts. So what did we do? I should say this is a pilot study that has now been expanded into a much larger study, but I'm just going to talk about the pilot study data here. We looked at 20 football players who were college football players, and about half of them, 9, had a concussion history, 11 did not. And we compared them to 12 people who were athletes but were not in contact sports. So these were all swimmers who did not dive as part of their competition, and track and field athletes. We did retinal imaging with optical coherence tomography, or OCT, and then also recorded or looked at imaged their vasculature in the retina, at the center of their retina, the macula, with OCT angiography. We only looked at the right eye here because these football players were involved in a number of studies and had very limited time to go to the medical center, and so these were all fairly quick exams. We also did record, though, retinal function with flash electroretinography. And then the head impacts during the season, practice, and games were recorded with these in-helmet accelerometers. So basically, we did collect the data on history, demographics, did OCT and OCTA and ERG at the beginning of practice when people first came back to school in August, and then redid that after the season ended, and then again 4 months later. For people who are not ophthalmologists here, but who may be familiar with brain imaging, I did want to emphasize that retinal imaging is very different in some ways. It's really low burden on the patient. So here's in this image here, you can see the woman in like the reddish, purplish sweater. She's looking in this device, and essentially you're staring at a fixation cross, and you have to stare for a few seconds with your eyes open. But each scan, then each image acquisition just takes a few seconds. This can be done without use of eye drops. Nothing has to touch the eye or go in the eye. So it's fairly user-friendly and quick as far as any type of imaging goes. The images that you acquire from OCT look sort of like higher resolution versions of parts of this image. This is kind of a very wide field image of different parts of the retina, with the macula here at the center, where this indentation is, with the fovea in the middle. And then, so we record, for example, all the neural layers of the retina and the thickness of some specific neural layers in this region. And then over here at the optic disc, recording usually just the thickness of this nerve fiber layer, the axons of the ganglion cells, just adjacent to the optic disc. For OCT angiography, you get images like this. This is of the macula. This area here is called the foveal avascular zone, where there are really very few blood vessels to ensure nothing interferes with light hitting the central retina. But around this, then you see this dense network of blood vessels. And so OCT angiography can measure the thickness or the density of those capillaries and see if that's reduced or increased. So essentially, our results look like this. This graph shows, if you look over here on the left at preseason, that the football players with the concussion history, so they're in blue here, had significantly thicker central subfield value. So that central area of the macula was thicker than the football players without concussions. They're in green. And then the track and swim athletes who were in kind of red or maroon colored here. It was quite a large difference. The effect size was actually over 1.0. And then the same pattern was observed at postseason, and pretty much the same pattern was observed at the 4-month follow-up. So this really was saying that the football players with a concussion history showed this thickening of retinal neural tissue. It didn't change much during the season. And it seemed to be a long-term effect rather than the effect of playing football. And the graph, I'm not going to show it here, but the graph for the retinal nerve fiber layer, just that one layer out at the optic disc, the findings are almost identical here. So there was evidence of thickening of neural layers in the retina in these football players, especially the ones with concussions. And then we looked at the how the number of times they were hit in the head during the season was related to some of these retinal findings. And what you see here on the left is, first of all, on the x-axis is the total number of head impacts during the season. And you can see this is not like 7 or 8 times they hit their head. This is in the hundreds with, you know, the mean, I don't actually have it here, but it's, you know, somewhere around 200 times. Anyway, the more times you were hit in the head, and this is regardless of how severe even the, how much force it was, which we also did record, but the more times you were hit in the head was associated with thickening of the macula. So an increase in the micron, the measurement of micron, thickness in microns from before to after the season. And this graph on the right is measuring total impacts as a predictor of changes in the cup to disc ratio, which essentially has to do with the widening or the width of the optic disc. There's a certain width that's normal. As it starts to get wider, that's usually a sign of neurodegeneration. And so again, these are some fairly strong relationships among the total group of football players. And the number of head impacts during the season was also related to increased perfusion density. So an increased density of blood vessels and a reduction of that area that was normally free of blood vessels. So it's as if there's this kind of thickening and increase in blood vessels that are abnormal as a function of how many times you're hit during the season, regardless of concussion history that you had. I want to just briefly say that we recorded electroretinography with a portable handheld device called the RetEval made by LKC. This is held up to the person's eye. There's a skin electrode that goes under their eye. It's on both eyes, but in this case, you can't see the one that's covered by the device. And basically what the person looks at for about 30, 40 seconds is flashes of light at different intensities and with different backgrounds, and you're recording the activity of the retinal neurons to these flashes. And a typical waveform that you would get looks something like this, where you have the A wave, a negative going wave reflecting photoreceptor activity strength. And then you get this very large B wave, positive wave reflecting bipolar, and which is a neural cell, and then Mueller cell activity, which is a glial cell. And in some conditions, you can get a further negative wave called the photopic negative response, which is looking at or reflecting ganglion cell activity. So without showing a lot of graphs here, I wanted to mention that if you could imagine the graph on the last slide, which I'm trying to get back to, and then imagine that exaggerated where you stretch it out vertically. That's what the waveforms look like for the football players with concussion history. So where the A wave is normally negative, it was more negative in the football players with concussion. And when the B wave is a positive wave, it was more positive, so it was higher. And that was found at all 3 time points. Again, just like the macular thickening, it didn't seem to be affected so much by what happened during the season, but it seemed to be an effect of having a concussion history. But the total number of head impacts they had during the season was also related to how exaggerated the waveforms were. So it was as if there was both an effect of concussion and recent head impacts. So some of our overall conclusions from this was, first of all, you can definitely see the effects of concussion history, even if the last concussion was quite a while ago. You can see that in the eye, and you see it as, at least in these young people. Now, it may be different in older people who are years after, they're not playing anymore. But at least in these younger people who are still active athletically, you're seeing thickening of neural tissue at multiple points in the macula and hyperexcitability in retinal neurons. At the same time, having more head impacts during the season was associated with even more thickening of the macula and widening of the optic disc, and increases in vascularization in the central retina and hyperexcitability of ERG waveform. So they were both longer-term concussion effects and short-term effects of playing in the season. And what was interesting was the correlations between the number of times they were hit in the head during the season and then the change from postseason to 4-month follow-up were in the opposite direction in general, meaning that the people who had more head hits during the season, who then showed more thickening and more of neural tissue in the retina and more hyperexcitability of neurons from beginning to after the season, showed thinning of the retina from end of season to follow-up and reduction in amplitudes of the ERG from postseason to follow-up. So there was some normalization, which is encouraging, but never got back completely in normal. And of course, we only did a 4-month follow-up, not like a 3-year follow-up, so we don't know ultimately what the long-term changes are. I did want to mention here, say something about what might be involved in these changes. There's a number of ideas out there in the literature. Head trauma, we know, is associated with an upregulation of neurofilament levels, which has to do with essentially the skeletons of the cells. When there's head injury, those proteins essentially that make up the walls of the cells break apart. They can be found in the blood, and this can lead to thick increases in axon diameter in the retina and neural layer thickness, followed by atrophy later. And that seems to be what we're seeing in a number of neurodegenerative diseases and possibly in TBI. It remains to be seen whether we'd see that in these repetitive head impact football players. We also know that repetitive head impacts are associated with microglia activation, which can also lead to inflammation and retinal thickening. And there's a process, again, called reactive gliosis, where the Mueller cells, a type of glial cell, they initiate changes when there's been injury, which can include neuronal hyperexcitability and enlarged cell body size. So one or more of these things may be involved, or it could be other things. We don't really know yet what the mechanisms are of these changes. Some of these, especially gliosis, are meant to be protective, but if there's continued, just like inflammation, if there's continued activation of these processes, they become neurodegenerative. So to finish up, I just want to say, in terms of future directions, Jeff Bazarian is doing a study now that's a follow-up of this with much larger samples over multiple sites, which is really what we need to see if these findings hold up. We'll be looking at shorter term changes, so not only across one season, but even before and after a single game of football, but also longer term, 1 year or even more after the season ends. So that'll be very informative. We're also collecting blood markers to see really to what extent these changes might be related to inflammation and to what extent these changes predict changes in vision and cognition. And ultimately, longer term studies can help us identify when, let's say, some of the thickening might shift over into a more degenerative process that leads to thinning, as we see in many other conditions. And finally, I wanted to mention that this work, which in a way comes out, is inspired by or motivated by what has been found in military personnel and veterans, has a lot of relevance to military studies, because we know that exposure not only to head injury, but repetitive head impacts from blast exposure causes problems similar to what is seen in athletes. So this is a recent paper of mine that reviewed the potential applications. And there I see constantly that blast exposure, even without open head wounds, are related to depression, to suicide rates increased, and to, of course, long-term cognitive and brain changes in military personnel. This seems to be especially the case for people exposed to explosive, but it's not limited to them. And in a recent New York Times article, they were talking about how the people who operate the boats that take the Navy SEALs out to where they're going to do something, even they are developing some of these symptoms and CTE-like symptoms because of the force in against their brain just by going so fast over waves on bodies of water. And it's also thought that in addition to military personnel and athletes, that people who are, let's say, construction workers and other people, again, who are exposed to strong vibrations and loud noises can develop these effects. So this was, like I said before, a very collaborative study. It could not have been done certainly by my group alone. This had great collaboration with Dr. Ramchandran and Dr. Bazarian, as well as Brian Kane, shown here, and a medical student, Jason Atlas, as well as people in my lab who are also named and shown here. And that's my last slide. So thank you for your attention.
Wonderful presentation, Steve. Thank you so much for. Oops, looks like there's an echo. How about now? There we go. Thank you so much for that great presentation. And it shows, we in the world of vision look at the eyes all the time, but they can tell a lot about the rest of the body as well. And professionals in other fields are now looking at the eyes to tell a lot more about the body, especially in Rochester. We talk about the biopsychosocial nature of medicines. The eye can really talk about a lot more than just what we're doing with vision. So this is a great testament to why it's important to examine the eye and why the eyes are going to be more and more important, I think, overall in the examination of the body. I did have one question to start off with. We in the world of eye care are so familiar with all these instrumentations, and now these instrumentations that we use, like OCT, are going to folks in places where you're not using them as much to diagnose eye issues, but you're looking at other correlations and associations with the structure of the retina and what you're finding in the brain in this case. How do you kind of gauge the ideas or some that eye care providers may say, well, you have to be also looking for subtle diseases in the eye, or there's subtle changes actually in the retina that may be contributing to what you're finding as associations in the brain, and vice versa.
Could you repeat the last part of that question again?
Yeah. So how do you answer folks in the eye world where they may say
All
that
right.
you're not noticing subtle changes or anatomic disease state changes in the eye itself that may be contributing to the findings rather than actual correlation between what's happening in the brain and the eye?
Yeah, well, in some of the studies, as you know, since you did a lot of the work yourself, we actually had the subjects have a full like slit lamp exam, the whole eye exam from an ophthalmologist. Not in all studies, but even in studies where we haven't done that, we often have an ophthalmologist, which is you've done it a few times, where look at all the OCT images and fundus images, which we like to take, and based on your advice, now we've gotten an axial measurement tool. So I think one of the things I've learned coming out of psychiatry is it's yes, you can't just get a quick measure of an OCT image and then assume you have ruled out every other possibility. So collaboration with ophthalmologists is very important. And of course, doing a thorough check of medical history. Sometimes we rule out people who've had, diabetes or hypertension or other types of conditions, which was quite easy to do in the football player study because generally they were young and healthy. It's much harder when you're studying people in their 50s or 60s who, may have had other conditions. And, we routinely also look at things like smoking and weight, obesity, other factors that can affect retinal health.
There's quite a bit of chatter here on the chat box, so let me get to some of these questions that are directed to you, Steve. Dr. Brizano says it's a great talk, so thank you for that. He wants to know, he's also a retina specialist, one of my colleagues here, where there's any segmentation performed in terms of looking at macular thickness to determine specific changes, the different layers. I don't know if we got that detailed. And were vessel density or other parameters by OCTA examined, or just the foveal vascular zone?
So for this particular study, there was a small number of subjects and there were many, many variables. So we deliberately tried to minimize them, what we actually looked at. We actually didn't get things like vessel width with the software that we had for this study. I think we did look at like ganglion cell layer and our plexiform layer, combination. But I think those data just pretty much had the same findings as the macular thickness overall. And so we didn't even report those in the paper.
Another question by Brian, who's an optometrist at the University of Rochester here, is were there any correlations done with vision or any other acuity measurements, such as contrast sensitivity, and the OCT findings?
Yeah, that's a good question. We did look at some of those correlations. The thing was the vision was very good in these people. Essentially, there was a restricted range from a statistical point of view. So we did look at some of those correlations. We didn't really see correlations with acuity or low contrast vision, low contrast acuity, but it was, I would say statistically, I wouldn't say that there is no relationship out there if you were to study a larger people, and especially over time, where you might expect some deterioration of vision. So that was an issue. And same thing with cognition. Again, you're studying college students. For the most part, other than visual memory, there really, or verbal working memory, there wasn't even a difference between the groups. Whereas as we know that like contact sport athletes after many years typically do show more impairments. So I think in the paper, one of the things we said was that it would be interesting to look at this in older athletes or people, with longer periods after, let's say, college, and see if some of these relationships emerge. But we really weren't able to test that given the small range and very high scores.
And Bob also talks about NFL, the new NFL helmets. I don't know if we all can answer that, but maybe Jeff needs to be here to answer that, Dr. Brazarian. How effective are these new helmets been shown to prevent concussion? Do you have any information on that at all?
Well, my first thought is, as a long-suffering New York Jets fan, I've tuned out of football. But that, I guess, doesn't really answer the question. I don't know how effective they are. I have heard that, I think we sent out an article to each other a few months ago that players don't seem to want to wear them, even though at least the NFL is saying that, or the company that made them, that there's some evidence they're effective. But as far as I know, there's no definitive, data on that yet. But I'll tell you, when you watch a football game and these are bigger and faster people than in college football who've been playing for years. It's hard to imagine that any helmet would really be protective.
And another question is anything to do of the RNFL thinning. Is there any remediation of that over time with, any therapies for concussion?
Yeah, you know, what I know about that is limited to the psychiatric literature or some of the medical literature. I know that people who have sleep apnea, obstructive sleep apnea, who generally also have retinal thinning, um, can have that improved or reversed, if you will, with CPAP treatment. What's actually happening is less clear. You know, is it just like um, axons and dendrites are growing, or is it cell bodies coming back? I mean, it's less clear what actually is happening, or is inflammation going down or up? I mean, it's a big question mark. In the psychiatric literature, they found that people who get ECT, which is usually reserved for people with very treatment refractory depression or psychosis, they have shown normalization um, of retinal neural layer values after ECT, which is known to be related to neurogenesis in the brain. But in terms of eye disease, I don't really know. This is a question I would turn over to you and other eye experts.
See. A lot of questions on TBI. If you have any questions for Dr. Padula, please do also let us know. But I do want to bring him on because this is a moderation of both talks here. In terms of Dr. Padula, in terms of rehabilitation efforts on your end, what is the best way for a patient to enter that? Do we refer to low vision, or who do we refer to when we have this issue with concussion? Because concussion goes to neurology, and so as an ophthalmologist, I don't really see the end result of where these patients go.
Well, many of them don't get referred.
Mhm.
Patients that I'm getting referred by retinal specialists and ophthalmologists are coming direct because the doctors have spent some time trying to understand the implications of the injury in relationship to quality of life and function. There definitely needs to be more of an integration of the model of neurovisual processing as opposed to a functional model or just a medical model. Just treating a medical condition is not necessarily going to affect how the visual process is organized in the system. And that's a critical factor for the rehabilitation of these patients to determine maximization of potentials. So from my experience, there's definitely more of a need for integration of the concept of neurovisual processing into programs where patients are being seen. And that's primarily in neurological areas and rehabilitation hospitals. And from my experience, there are many more doctors of optometry practicing neurooptometry that are now on staff, including myself, at the rehabilitation hospitals.
And you talked about the woman had prisms, and do you also talk about any nutritional supplements or any dietary changes when you're managing these patients?
Well, certainly, those things are very important. And the discussion that Dr. Silverstein just provided in talking about changes in the retina brings us right back to the very core of thinking about the nutrition and the nutrients that will affect the macula and the peripheral retina. I do work with patients on dietary discussions, but I also refer out to naturopathic physicians and nutritionists to create a greater support of integrative care.
And a question here also asks about billing codes, some of the practical matters about billing for these patients. Are there various codes that are billable when you do see these patients?
But right now, they're the standard codes, but post-trauma vision syndrome and visual midline shift syndrome are being reviewed now. So hopefully we'll have codes for those. However, there is a visual spatial dysfunction code that both post-trauma vision syndrome and visual midline shift syndrome will be allowed. In addition to that, I use the code of anisoconia because anisoconia is a distortion of space. So that works very effectively for both, particularly visual midline shift syndrome, but also post-trauma vision syndrome.
And one last question, I'll turn it over to Josh, who has some questions for you as well, is how exactly those prisms actually work in that patient that you showed to change in their spatial processing issues?
You're referring to the young man who was walking, holding on to the wall.
Yeah.
So it's quite obvious that he had a shift to the right in his visual midline. So think of yourself walking on a slanted floor where it slants down on the right side and it's up on the left, although you don't see it that way. But your brain is perceiving a compression of space on the left side and an expansion of space on the right. And many of these patients will push their hips to the right and posture their head back in the other direction as a cantilever. In the case of this young man, utilizing the yoked prisms with a base end toward the left, the base end expanded space and the apex compressed space. Now that's a bit simplistic because a prism is quite complex, and the apex expands space laterally, but compresses space in the z-axis, whereas just the opposite occurs in the base end. So understanding this on a three-dimensional model, you are literally rebalancing the brain in terms of its concept of space, but particularly in relationship to organization to be upright against gravity. So that z-axis becomes a very critical component to it. But in a nutshell, the base end of the prism is always placed toward the affected side, or the side by which they are not increasing weight bearing to.
Josh, did you have anything else to add there? I'm sorry, I usurped all the time here for questions.
No, I'm just seeing a few more popping up here. One about photophobia and concussion. They asked, is it a localized retinal phenomena or more of a cortical phenomena?
Very good question. My experience with that is that it's not traditional photophobia. And if you understand what's happening when a person has a compromise to the spatial process, the visual system through the central parvocellular system occupies the majority of organization of the process then. It only knows how to do one thing. It sees detail. It essentially turns the forest into trees. What I find most of these patients have is overfocalization and something that I've termed focal binding. They lock onto detail and they have a very difficult time releasing from it. There's a condition called dazzle, and dazzle is an overload of the visual process. And in my experience, what I found is that it leans more toward the dazzle than photophobia. It's an overwhelming experience of information coming in through the wrong channel. When we treat them for post-trauma vision syndrome with base end prisms, and when they come back in and they also have improvements with convergence, one of the things they also report is that their photophobia has diminished and light sensitivity. So I think it's just a different way of looking at it. I think you have to look at it from the processing perspective, not so much as the light stimulation effect.
Okay. Another question here. Is the magnitude of the prism related to Fourier measurements or simply subjective trial and error or some other formula? And then along the same lines, are you using Fresnel kind of press-on prisms to begin with? How often do you follow these patients once you give them the prism, and how do you know when to decrease it?
In post-trauma vision syndrome, we're using low amounts of base end prism, 1-2 diopters, occasionally 2.5 diopters base end. So they're always slab off or ground in, occasionally decentered optical centers. For patients with visual midline shift syndrome, the majority of my patients work with very low amounts of prisms, between 2 and 6 to 8 diopters. I'll always use a slab off or ground in prism for those patients. Even for patients with stroke that require higher amounts of prism, I try to stay away from the Fresnel prism because there's so much distortion and blur in the Fresnel prisms. They don't respond well to that. So I usually go directly to a ground-in prism designed into lenses and evaluate them fairly regularly, because as they improve and organize the spatial visual process, bringing visual midline back to center, the prism can be reduced, and in many cases, or some cases, eliminated if there's not a neurologically involved side.
Okay. Very good. Kind of going through the chat here to see if there's anything else. Did we miss anything?
No, I think you got everything there. It's great.
Okay.
Everybody. I think we're a little bit over 9.
Yes.
Thank
Thank
you.
you both.
Felicity, Dr. Padula, Dr. Anchandra, Dr. Graff. Thank you so much, everyone, for attending. Rajiv, you wanted to say something?
I just wanted to thank our speakers, and thank you, Karen, for arranging this great talk. And it's a great start
Yes.
to a great series.